So why do you fail to penetrate? So often the lead is in a non-perpendicular orientation. The sheath is not, and the lead is not perpendicular. It's not sitting at an angle. And when you rotate, it's not able to penetrate, and it captures some of the fibrous tissue and gets stuck into the screw, and you're not able to advance. So making sure the sheath adequately supports the lead and try to keep the sheath as close to the tip as possible. Sometimes no matter what you do, it doesn't go forward. That means you need to know, have I really defined my tricuspid annulus well? Am I close to the tricuspid annulus? Those membranous area, fibrous tissue cannot advance the lead. Or you may be in the membranous septum itself. That's impossible to advance the membranous septum. In some patients, you're stuck in the mid-septum because he has coronary disease, some septal scar, or other kinds of scar tissue that can't advance the lead deep. And often, this is quite common, the tissue gets large in the screw. Getting those tissue out of the lead screw is very painful. Some people use a fine needle to pull it out. I usually have a little iris forceps that I use for cephalic vein cut down. Those forceps can tease the tissue between the screws without damaging the screw. Rarely trying to pull those tissue, you may damage the screw. You should be ready to replace the lead because bent screw, not only the future electrical characteristics, but also acute implant, and maybe even harder. And when I talk about orientation of the sheath to the septum, I've just twisted this in multiple angles. So imagine this is the normal interventricular septum. The RV is on this side. And in some patients, the RV is quite anterior, like this, the rotated around. And trying to get the sheath oriented perpendicular, if you come across using the landmarks I showed you, that 12 to 1 o'clock in RAO and 2 to 3 o'clock in LAO, may not apply in a patient that is fairly rotated. Some patients, excuse me, some patients may have pectus excavatum, the heart is even more rotated, or just by the RV enlargement. So at least in my mind, I try to imagine why is my lead not penetrating the septum. So I try to orient the sheath slightly differently, go from keeping it at the neutral position of the C315 sheath, go more counterclock, further counterclock, or then I stop all of that and come back and go a little bit clockwise and see if that will get me into the septum, if the heart is rotated in another way. So as long as the implanter, the operator, understands the sheath to septal orientation, then it becomes easier.